Welcome to AETCM, the emergency medicine chat. Shall we start? So, a 35-year-old male came to ER with complaints of acute onset altered behavior, fever, disorientation, and restlessness since one day. On initial 10-second assessment, airway was patent, no pooling of secretions. Breathing, respiratory rate was 18 beats per minute. SpO2 was 99 on room air. Coming to circulation, BP was 120 by 80 mmHg. Heart rate was 80 beats per minute. Coming to disabilities, GCS was E2, V3, M5. Pupils were equally and bilaterally reacting to light. Coming to exposure, patient was febrile, 100 degree Fahrenheit. Adjuvants to primary survey, we took a CBC CRP showing total counts of 19.2, HB of 12.2 gram per DL, platelets of 1,97,000, CRP of more than 230. We also took a VBG which showed a pH of 7.378 with bicarb of 25.2 and lactate of 2.1, no acidosis or alkalosis. Electrolytes were within normal limits. We also took an ECG which showed normal sinus rhythm. Coming to sample history, we had a patient, a 35-year-old with no non-comorbidities, came to ER who had initially developed fever with rhinitis, cough and headache, and was treated symptomatically from outside hospital. 2 days later developed facial swelling, acute onset altered behavior, disorientation, altered sensorium, restlessness and agitation. A patient was taken to outside hospital, and on examination he was found to had neck stiffness. So they had suspected meningitis and CT. Initially CT brain was taken which showed a defect in the frontal bone on the right side with extraaxial area of heterogeneous attenuation along with the defect and hypodense soft tissue thickening in the extracranial areas, possibly infective. Also had subcalial fluid collection in the subcalial region of the scalp. Patient had an history of childhood fall, post which patient according to the history given by the bystanders, patient had a defect initially from childhood, sir. And also that CT showed mucosal thickening in bilateral, ethmoidal, frontal, maxillary and left sphenoid sinuses of which was inspissated, and they were suspecting either a fungal or neoplastic etiology. So they have also done CSF analysis from outside hospital which showed total counts of 1071, 98% neutrophils.
In CSF?
CSF studies. Sugars were 31 by 146. Reduced.
What is the importance of sugar in CSF?
CSF should be 2/3 of the normal serum
You are
glucose.
talking only about CSF sugar. What is the corresponding blood sugar?
Patient's blood sugar was 146, and
what is the importance of this?
2/3 of the serum is normal levels.
So here it is less than
normal.
So what does it mean?
Usually seen in bacterial meningitis, blood sugar.
TB?
In TB also it is reduced.
TB also bacterial. All bacterial meningitis it will be low. All viral it may be normal. There are very few viral diseases it can be low. Like mumps, meningoencephalitis and all can be low.
Protein was 679. Normal is 250 to
Proteins are elevated in what all types of CNS disorders?
Tubercular and bacterial meningitis.
One is meningitis. Whether it is bacterial, virus, fungus, TB, everywhere it will be elevated. Where else? Elevated protein. Where you get albuminocytological dissociation? Guillain-Barré. When there is an inflammatory alone, not infectious. Inflammatory only condition also it will be elevated. So high protein without elevation of cells are classical of GBS. Okay. Even transverse myelitis you can get. Okay.
They have also done CSF biofire which showed a streptococcus species.
Okay.
So they have already initiated treat from outside. They had initiated on injection meropenem 1 gram IV TID and injection vancomycin 1 gram IV TID, and the patient.
So how do you manage a meningitis in your emergency room? So somebody has treated well. I'm just asking you, how do you manage if you are getting this case as a first line drug therapy in meningitis?
Initially,
How do you
we'll
manage?
have to give steroids.
How much?
Dexa 4 mg or 8 mg IV stat can be given.
Why dexamethasone?
Sir, if patient encapsulated organisms that can rupture and cause inflammation if we have not
Why
initiated.
dexamethasone? Why not other drugs?
It will cross
It will cross the blood-brain barrier. Okay, so dexamethasone has to be given prior to antibiotic. Then
depending on what we are suspecting.
Then will you send for MRI first or LP first? You have to tell me. MRI first. So you always try to send MRI. Even when you get altered, like if you do LP first, then there can be altered signal intensities in MRI. So MRI first, then
LP has to be done.
LP has to be done. Antibiotic.
Antibiotics.
So suppose MRI is delayed, LP is delayed, will you not start an antibiotic?
No, empirical antibiotic has to be started.
So you don't need to wait for once you rule out a bleed or something in the brain, that's why we are taking MRI. Before LP we do it. Then we have to start the antibiotic. Within half an hour of your steroid, you can start the antibiotic. You don't need to wait for the confirmation by LP because it may take more time. Okay. So what antibiotic as a physician you start?
So depending on what we are suspecting, if we are suspecting gram-positive species, then we can initiate on injection ampicillin or ceftriaxone. Ampicillin.
In this patient, what is the age of the patient?
It's 32 years old.
32-year-old male who is having defect in the cranium. What organism you may suspect and what will be the first line choice in your treatment?
Most probably
You tell your treatment.
Yes.
What you learned from the guidelines. What is your treatment? Ceftriaxone and? What is your treatment of choice? Vancomycin. So first line of treatment is in most of the case of encephalitis, meningitis, if you are suspecting bacterial, it is ceftriaxone with vancomycin. Okay. If you are not suspecting MRSA or you are not come across any MRSA in your area, then vancomycin can be removed or instead of that you can go for some other drug. But ceftriaxone is mainly for gram-negative infection. So vancomycin or crystalline penicillin or like you told, what you told? Ampicillin. So that is for gram-positive and listeria. Okay, listeria is mainly occurring in elderly or very young. Okay, in that extremes of age you use ampicillin. So what is the dose of ceftriaxone?
70 to 100 mg per kg.
Per kg body weight.
Okay. He will give 2 gram IV.
Okay, meropenem, if you are giving meropenem?
1 gram IV, 80 kg.
It will be very high dose. 2 gram IV TAD is a usual dose for adult. Okay. So they have started meropenem with vancomycin.
And also steroids were initiated.
Okay.
On arrival here, patient was restless, disoriented. On examination, patient was restless, not oriented to time, place and person. Coming to CS examination.
So here you got a biofire finding suggestive of gram-positive cocci. So what do you do with your steroids? Stop? Continue? Continue. So you have to continue. If it is streptococci, then definitely you have to continue. Okay.
On CNS examination, GCS was E2, V3, M5. Pupils were equal and bilateral reacting to light. Neck stiffness was present. Brodinskians and Kernig signs were absent. Bilateral plantars were extensors. We had taken, post that we had taken an MRI brain with contraster, which showed an acute infarct in right frontal semi-oval.
What do you think that infarct is? How the meningitis patients develop an infarct in the brain? Sometimes you can get cranial nerve involvement, focal neurological deficit, or like you told in MRI you'll see isolated infarcts. How do you explain all these things? How do you explain a patient who is having meningitis with cranial nerve involvement? How do you explain a patient with meningitis with focal neurological defect? How do you explain that this patient, like this patient, MRI shows a finding block? Is it a atherosclerotic plaque?
No, sir.
Then what else it is? Infiltration of, what is it?
Vasculitis.
Arthritis, endarthritis by the infection. Okay, so here it is not due to the atherosclerotic disease. It's mainly due to the involvement of the infection in the meningeal arteries. Meningeal artery means it can spread into from the brain. It can same process can even go to the brain also.
The CTPNS showed bilateral ethmoidal frontal left maxillary sinusitis.
Okay.
1 hour EEG was
How do you know that this infection is spread from the nasal cavity or sinus to the brain? Ideally, what has to be done? You have to take a culture from there also, from throat swab, nasal swab, or sputum should be collected from the sinus. Then you have to correlate whether both are same or not.
Then we had initiated on ceftriaxone 2 gram IV TID, vancomycin, and continued with steroids.
Okay.
Patient's CRP later was downtrending with total counts. Patient sensorium was also becoming better. We had given an ENT consult.
He had cerebralitis also. What is the pathology behind that? Same thing, what we explained. Arteries can be involved. Cerebralitis is well known in many types of meningitis. Okay.
We had given an ENT consultation in view of sinusitis, and the patient was advised to give saline XL nasal spray TDS.
Okay.
And in view of acute, in fact, we had also given consult to neurology, and the patient was started on single antiplatelet agent.
Okay. We continue it indefinitely, or we can stop it afterwards?
Indefinitely, yes.
It's an infectious process, and transiently they might develop all these things. There is no reason to continue, you can stop it. Because if the cholesterol is normal, if he is not a smoker, then better to stop it. May not be required.
Meningitis is defined as the infection of meninges with a combination of fever, headache, and meningism. Meningoencephalitis is
Meningism is what?
patient having
Neck
stiffness,
rigidity when you are flexing. Where all you get meningism other than meningitis?
SAH, transverse myelitis, Parkinson.
Transverse myelitis. Transverse myelitis is in the spine. No? Where should you get transverse myelitis?
No, sir, Parkinsonism.
Parkinson's. There also you can get neck stiffness, but that is a mimicking condition. Okay. Cervical spondylosis. But the most important is subarachnoid hemorrhage.
Subarachnoid hemorrhage.
What is Freund syndrome? Freund syndrome. Freund syndrome. You have to read about that. One of the conditions which can mimic encephalitis or meningitis, where the CSF shows high proteins. Okay. Freund syndrome.
Classical triad seen is headache, fever, and neck rigidity. Change in mental status is when brain parenchyma is involved. Patient will have confusion, increased sensitivity to light, and nausea, vomiting. Sometimes patient can also have cranial nerve involvement and rashes. The signs which we see in
the patient is having rashes in meningitis. What will you suspect? What precaution you take as an emergency doctor? Meningitis is there. Patient is having rashes all over the body. What precautions you take? What antibiotic you choose? Is your choice? What other investigation you do? How do you assess the blood pressure of the patient in that type of patient?
meningococcal meningitis.
Meningococcal meningitis. How do you make precaution to prevent? So you have to use you have to use all the personal protective equipment. Then what else you take? What is antibiotic of choice or adjuvant antibiotic, and what precaution you take? Which drug is useful there other than what all we have discussed here? It is used in TB. Rifampicin.
Rifampicin.
So rifampicin prophylaxis is required for physicians. Okay. What BP abnormality they can have? Waterhouse-Friderichsen syndrome means what?
Adrenal gland
That adrenal gland?
hemorrhage.
Patient can have severe hypertension.
Adrenal insufficiency.
So rashes with meningitis, you should be very careful. When you are treating the patient, you should use all personal protective equipment to take rifampicin. Then check for the bacteria which is involved. If it is negative, we can discontinue all these things.
Signs which we see in our Kernick sign is when we flex the hip joint, then extend the knee joint. It is impossible to straighten the knee due to spasm of hamstrings. This is because we'll stretch the roots of sciatica nerve, which are exits from the spinal theca. Then neck stiffness.
How do it differ from straight leg raising test?
In straight leg, we are not flexing.
We are not flexing. Where you get that?
Sciatica.
Sciatica. Lumbar radiculopathy.
Radiculopathies. In Brudzinski sign, on passively flexing the neck, both legs flex and at knee and hips. And also we can see neck stiffness. The examiner is unable to put patient's chin on the chest by passive flexion of neck due to neck muscle spasm.
Okay.
Coming to causes of meningitis, the most common, depending on the age of onset, in young child, it can be H influenza, type B H influenza. Less common is Neisseria meningitis and pneumococcal and M tuberculosis. Coming to older child and adults, 50% is pneumococcus or group A streptococcus. Less common is M tuberculosis and Staph aureus. Following any neurological procedure, most common organism is Staph aureus, Coagulase negative streptococcus and Pseudomonas.
Okay.
Post-trauma, most common is S. pneumonia. Chronic meningitis is seen when the symptoms precedes more than 4 weeks. It can be both infective or non-infective. Infective is when there is TB, neurosyphilis, Lyme's disease, mumps.
That is Mollaret's meningitis. Mollaret's meningitis. You have to read. You have to read all these things. When you are talking about chronic meningitis, that is one of the differential diagnoses.
In non-infective, it can be due to mets in the brain or inflammatory like sarcoidosis or vaginous granulomatosis. Coming to investigation, initially we'll have to take an MRI brain with contrast. We'll usually see inflamed meninges, contrast enhancement. Then coming to lumbar CSF study, we'll have to see the following parameters to differentiate between viral, bacterial or tuberculosis etiology.
How do TB and bacterial differentiate?
In bacterial, predominant will be neutrophils. In TB also initially, later on lymphocytes predominant.
Initially what will happen in TB?
Initially neutrophils.
Neutrophils. Later?
Lymphocytes predominant.
In bacterial?
Initially neutrophils, later mono
lymphocytes. Then how do you differentiate?
Then the color, patient protein.
Protein will be more in TB,
in
but
TB.
it will be there in even in bacterial also. Then how do you going to differentiate bacterial versus TB?
AD.
Who told? AD is not useful in CSF. It is useful only in
Pleural
fluid. What else? TB is a chronic process. It takes at least 2-3 weeks before developing all the problems. So patient will have mild headache, mild symptoms, mild fever for many days, more than 2 weeks. But bacteria will be an acute problem. Within 1 or 2 days, patient develop all, like your patient. Within 2 days, patient develops severe headache, vomiting, neck stiffness, all this thing. That will not happen in TB. It's a slow process. Okay. Otherwise, it will be very difficult to recognize whether it is TB or this one. You have to send PCR. PCR will be very useful tool. PCR in TB, PCR in culture in bacterial meningitis. That may be helpful. Not ADA. ADA is not a useful test in CSF.
Coming to treatment, meningitis in children less than 3 months, suspecting gram-positive ampicillin 2 gram IV every 4 hours, plus cefixime 2 gram IV BD. Ceftriaxone 2 gram IV BD. In children more than 3 months and adults less than 35, we can give benzyl penicillins 20 lakh units every 4th hourly, or ceftriaxone 75 to 100 mg per kg IV BD with vancomycin 50 to 20 mg per kg IV TID.
Vancomycin adverse effects? Kidney and
Kidney injury,
ototoxicity. Kidney is most important. Is it a cumulative effect or single dose effect?
Cumulative
So
effect.
when will you check the creatinine?
Trough level.
Okay.
Hospital acquired or post-traumatic or immunocompromised patient will have to give vancomycin, meropenem and ceftazidime 2 gram IV every
Ceftazidime is used for?
gram.
Ceftazidime is specifically used for one bacteria. It can be used for all gram negative. It's a anti-pseudomonas cephalosporin.
And steroids also initially, and should be continued if a patient is having.
Where else you use steroid other than streptococcal pneumonia, streptococcal meningitis? Where else?
Tubercular meningitis.
Tubercular meningitis also you are supposed to use steroids. Okay. Anything else? Nothing.